Hi, everybody. Welcome to the Hypertrophic Cardiomyopathy Association's Facebook page. And you are part of our series of Meet the Experts. And today we have Dr. Srihari Naidu from Westchester here to discuss this, the new second edition of the textbook on hypertrophic cardiomyopathy. So welcome, Dr. Naidu, who shows up as Cath Doc on Facebook.
Yes, thank you very much. I'm happy to be here. Yep, Cath Dog, that's my nickname on Facebook.
Okay, well, now everybody knows how to find you there. So we're going to talk a little bit about this book, and it's not a small endeavor. This took several years to complete. It's been out for a couple months now, and this is just unfortunately the first opportunity we've had to have this conversation. So first, tell us why a second edition of this particular textbook?
Yeah, so as you know, I was on the guidelines back in 2011, and I think it became very clear that we're trying to get centers of excellence, trying to get a lot of doctors to know about this disease, but it's one of those few diseases that most of the information is left in the hands of a few people. It's you, it's the physicians who've seen thousands of patients. And so the question is, how do you get information that's in some ways a lot of anecdotes and observational experience, and you can't have everybody in the country seeing thousands of patients, so a book makes sense there. I mean, people would say books don't make sense for a lot of diseases because a lot of the diseases are out there, but something like this, how do you get people to understand how to comprehensively take care of a disease like this? Well, a book makes sense. So we went on this endeavor in 2011. It took 3 years to get the first edition out in 2014. And then the second edition came out, and as you can see, is much larger. It's almost 500 pages, 31 chapters, 70 authors, board review questions at the end of each. There's like 500 questions. The reason for the second edition was really to make it what I wanted in the first edition, to really finally get to a book that was really comprehensive and had everything in there. There's an art to taking care of these patients. And so this book in some chapters really tells you, how do we see them? What do we do on the first visit, the second visit, the third visit? What are the practical aspects of treating them? Now as I go around the country and speak at different centers, they're buying the book and looking at it, and then they're reading it like a novel, so that they can really within a week or so, if they read all those chapters, they kind of have a good sense of how to take care of these patients, at least on the baseline level.
So a couple thoughts come to mind as I look at this and the depth of the book, as well as all the citations that are in there and all the fantastic articles that were drawn from to put this book in one place. I'm struck with the concept that I know, and many of those who follow the HCMA know, that HCM is complicated. It doesn't run by the same treatment modalities that many other diseases follow. Here's your problem, here are your logic trees that you have to sparse out, and there are 1 or 2 or 3 endpoints that are potential. We have so many various anatomies and so many different areas to consider, whether we're dealing with heart failure, whether we're dealing with obstruction, whether we're dealing with arrhythmias, atrial arrhythmias versus ventricular arrhythmias. There's so much here, and it's so complex, which is why we went with the concept of centers of excellence to treat people. But even when somebody says, hey, Lisa, I'm interested in starting a center of excellence, where do I start? That's a complicated question. And now the answer might be, here's a book. First, read the book. Then come back to me and say, I really want to be involved with this or not, because it's complicated.
Yeah. I think you're absolutely right. I think you and I have been doing this a long time, you longer than me, but I think when people want to be a champion in this, the first thing that you've assessed, obviously, is, are they really serious about this? It's much more complicated than people think. You have to do an amazing amount of deep dive into the disease and really take the time to understand it. And so if they can read that book, and if they can stay interested in it more than a few months, and they have the resources, then that's what'll do it. But you're right, it's very complicated. It's complicated enough because as people get older, they have other diseases that interact with it. And a lot of it's pattern recognition. If you have an AFib patient, well, it's different in a 35-year-old than it is in an 85. Do they have other heart problems, or they just have the hypertrophy? Is it diastolic dysfunction? Is it MR? What is causing it? It takes a long time. And so I think the book helps for an initial stab at each of those disorders, but then the network you've created, the network that we've created to be able to pick up the phone or call someone and say, I have this patient with AFib, or this patient, what is their risk of sudden cardiac death, or have you seen this before? I think that's where we're going. But the book is a good starting point to get people.
Tell us who contributed to this book. It's not just you and me. And
no, I mean, I think,
30?
there's 70 people in this book. I think
70.
the first time I did this book, I reached out to basically all the centers of excellence and asked them to get involved, at least their leaders at each of the institutions. This is not just in the US, it's also international. But you have the first chapter written by Dr. Braunwald, who did the history, and as you know, he was instrumental in the initial diagnosis of hypertrophic cardiomyopathy, and it's amazing to hear his story. Then we had Dr. Gersh give the foreword in both of the editions, and then we have surgeons from Dr. Swistel to Dr. Saraja doing alcohol ablation, to Dr. Ruskowski and MRI. Basically, it's a who's who of people involved in hypertrophic cardiomyopathy who spent their whole life around different topics there, from pediatrics to genetics, to imaging, to the advanced invasive therapies and heart failure and transplant. And new to this book, it became clear that there's a lot of patients who have other things, like how do you deal with coronary disease and hypertrophic cardiomyopathy? Ischemia definitely increases the risk of sudden death and decline in function. How do you deal with the blossoming field of TAVR and MitraClip? What kind of patients need that? How do you deal with the patient who ends up in the ICU?
Let's go back for a second. You said some big words there that aren't really known to many people in the community. So TAVR, let's just dive into what is TAVR and why would it be important to somebody?
Yeah, TAVR, that's a great question, because one of the problems that patients have with hypertrophic cardiomyopathy is they have a problem with blood leaving the heart. That's outflow tract obstruction. Well, the most common cause of outflow obstruction of the heart is something called aortic stenosis, which is a valve problem that, if we're lucky enough to get old enough, a lot of us have. But we're finding that some of those patients had hypertrophic cardiomyopathy too, and that might get worse as time goes by too. And some of them may develop the obstruction to blood flow from the muscle right at the same time that they're also developing a valve rustiness or a valve stenosis or a valve closing problem. And it's become a big issue because in some of these patients, we've developed a procedure to minimally invasively repair the valve. Now, that is relatively straightforward to do these days, and a lot of hospitals market it, and so patients rapidly go from a patient that now has this obstruction all the way quickly to fixing the valve, and that's called the TAVR. But if they have hypertrophic cardiomyopathy, it could be a disaster. So we're now realizing that some of these patients actually have hypertrophic cardiomyopathy. They don't have much aortic stenosis or valve problem. And other people have the valve problem, but then the obstruction from the muscle may get worse after, and some of them get really sick. Right. So as you know, lately I've been trying to talk about that more at different conferences and try to figure out how to treat these patients properly. Some of them don't need the valve replacement. Some of them just need the hypertrophic cardiomyopathy treatment. Mm-hmm. And other people who need both, oftentimes they need more complicated surgery or minimally invasive procedures like alcohol ablation to try to get them through both procedures. So it's a good question, because I think those watching, especially that are older people in their family with hypertrophic cardiomyopathy, they may hear the term TAVR, they may be pushed to have a valve replacement, but those are where you should say, hold the horses, let me get some more consultation by somebody who knows hypertrophic cardiomyopathy, make sure this is the right thing. And it might be, but you have to make sure.
Yeah, I've actually had a couple of inquiries from physicians around the country evaluating patients for TAVR and then saying, this might actually not be the problem. The problem might be hypertrophic cardiomyopathy. And so we're getting actually more diagnoses of HCM through TAVR programs.
Right.
And I get quickly mentioned mitral clip, which sounds really easy because it's just a clip. But is it so straightforward?
Right. So MitraClip is a different procedure to cure a leaky valve with the mitral valve. And that also, a lot of people with hypertrophic cardiomyopathy are confused with just having mitral regurgitation or leakiness of the valve. And again, you've been doing this a long time, so some of those patients actually, or many of those patients actually have hypertrophic cardiomyopathy, which causes a leaky valve that gets better just by treating the muscle. So again, if you have a leaky valve or mitral valve prolapse and you have funny symptoms, you might actually have hypertrophic cardiomyopathy. Make sure you see a specialist for that. And if it's hypertrophic cardiomyopathy, the treatments are not to touch the valve, generally speaking. There are some patients who mitral clipping might be an option, but really should be done at centers of excellence for hypertrophic cardiomyopathy and mitral valves, and which are few. And even that initial data of looking at mitral clip for hypertrophic cardiomyopathy was a little bit of a mixed bag. Some of those patients still had obstruction. Some of those patients did not have didn't last as long. So again, especially as you moved into valvular disease and valvular intervention and interventional cardiology, sometimes we jump really quickly to these things, and that's the time where, especially if you have hypertrophic cardiomyopathy, you should seek a more expert opinion.
We talked in the book a little bit about lifestyle, that's part of my contribution, and exercise.
Yeah.
So there's a bit of noise going on in our community about where's the line? Where's the line between what's good exercise and competitive athletics? I really wish we could put them into two completely different silos and talk about them as separate entities, because that's what I believe that they are.
Yeah.
But lifestyle generally, fitness, going to the gym, we all agree that that's probably pretty good for most people with HCM, right?
Right. Yeah, I think the challenge is that there's certain types of exercise that elevate your risk probably of sudden cardiac arrest in this disease, and that risk is relatively low for the majority of people, but there's a subset that's much higher, or significantly, or certainly too high for us to ignore. On the flip side, though, there's no question that you could live a much healthier life, a much better quality of life if you're more fit. So the question is, how do you stay fit without increasing your risk of sudden cardiac arrest? And so and also by staying fit, you probably can avoid some of these surgeries, some of these ablations, or at least push it off for several years, because I always use the analogy of sort of an engine that may not be the perfect engine, but if you put it in a smaller car, it's going to zoom around. And so there's no question that some people have hypertrophic cardiomyopathy that can impact the amount of blood that circulates, but if you are fit, you don't notice that. And the other analogy is that young people would have pretty severe heart dysfunction by the time they notice it, and that's because their body is relatively fit. And so we could use that to get us in better shape as we get older. Now, what I tell my patients is that means that you should keep a body mass index that's normal or on the thin side, and you should keep your cardiovascular system as fit and flexible as possible, meaning that the vessels should be flexible, the blood pressure should be well controlled, the muscles should be able to extract oxygen very well by being very fit muscle. That way, the heart actually doesn't have to work that hard, and if the heart doesn't have to work that hard, chances are it's in much better shape in terms of the risk of sudden cardiac arrest and the risk of getting more heart failure down the line. So I tell people, and you know this, there are certain rules I tell people in terms of what you should avoid. I tell people to avoid competitive athletics. That means avoiding anything where you're competing against yourself, the clock, or someone else. I tell them to avoid what's called burst activity, where you go 0 to 60, and that's sort of like singles tennis or full court basketball, Zumba, things where you're standing and then all of a sudden have to jump and do something, the adrenaline rush. And then certainly activities are definitely out. So on the flip side, I do tell people that you should be able to talk in full sentences when you exert yourself. And they like that one because people know what they can do. And then over time, you can gradually increase your fitness level to be able to talk in full sentences at a higher level of activity. And that gives you an idea that you can gradually get better and better. But it's a gradual thing. And eventually, you'll be in much better shape. And so I give them examples of sort of how to tone themselves, how to use light weights if they can, how to manage their calories in terms of their overall body weight, and the types of activities that they could do and how many times they should be doing it a week to try to gently lose weight and get more fit. And those are the recommendations I do. Okay.
So I will disclose something that I recently found out about myself, which I think actually was there a long time. So you said as you get older, you get other conditions. So I recently found out that I'm insulin resistant, which is kind of like almost opposite of diabetic. I make too much insulin. My sugar's perfectly fine. So I've had to cut out all sugar and white carbs, and all of a sudden the weight is starting to pour off of me. And I've always said carbs hated me. Do you think that there's any real value to patients with HCM getting, if they're having a hard time losing weight, getting full metabolic workups to see what their weight loss issues or weight gain issues might be related to? Hormones or overactive pituitary or pancreases or whatever?
Yeah, I think the whole pre-diabetes and diabetes is very difficult because people start gaining weight, they start getting insulin resistant, then they gain more weight, then they get more insulin resistance, then eventually they go into frank diabetes. And the question is, how do you reverse that? And you reverse it first by diet and minimizing. I think you're right. Minimizing carbs has turned out to be a very good thing for a lot of people. Higher lean protein, higher vegetables, and overall keeping your calories less than you were eating before, so you can ultimately drop weight. And as you drop weight, even if it's 10 to 20 pounds, the insulin resistance goes down. Then you're able to drop more weight. You get less hungry because insulin makes you hungry. and so you're losing more weight. But you have to sort of reverse the cycle from where you've been gaining weight and being more insulin resistant to starting to lose weight. You have to tip the scale over. And patients can't do that with the really crazy diets. I do not recommend a lot of these crazy diets because you can't sustain it. You have to go back old-fashioned, which is a combination of exercise as much as you can do and gradually increase that, and a combination of not calorie counting, but minimizing calories to your body weight so that your body weight goes down, then you need less calories, and your body weight goes down, and you need less calories. And the composition. So I usually focus on the total, what they're eating during the day, how many calories or what kind of consumption they are. Then I micromanage a little more how much carbs versus other types. And then I micromanage when they're eating. I tend to front load. If you do more breakfast and lunch, and then you wean off taper off towards dinner at 5, 6, 7 o'clock at most, and then you're kind of done, you end up training your body to be okay with that and not be so hungry late at night. And so eventually your weight drops and you find a new equilibrium that gets better and better. It takes time, though. It's a concerted approach between diet, exercise, and really not micromanaging every day. Like, oh, I eat this, so I can't eat this. So on a given week, you can have some slips. But in general, that's the kind of trend you need to be on. It seems to work, but it takes a lot of effort.
Yeah, I think we still need to do a little bit more research in there, because I do find that the number of people that I talk to in a given week, most of them are on the average plus, BMI, so they're a little bit heavier. And there's been some data that says we're a couple points heavier than average. I think that's because we minimize exercise, and I'm not necessarily sure that we are burning properly. And I think we need to be more aware of that and a bit more aggressive when it comes to weight loss when it's just too hard. Gastric sleeve, et cetera, has been very useful in a number of patients that I've worked with.
Yeah, I think you're absolutely right. And I definitely encourage patients when they get to a certain point where, as I mentioned, this cycle, at some point you can't tip the cycle back. You need something more aggressive. So I think it's right. And there's no question that some of those have their own complications and they're not for everybody, but certainly they do work. And for the motivated patient who's tried other things and is willing to do that and then reset themselves to an area where they can then use diet and exercise to maintain, I think definitely there's a lot of benefits to that. So that chapter that you wrote on lifestyle and obesity, I was very happy to have that chapter in the book because that's where a lot of patients need guidance. And that's one of there's probably 5 or 6 chapters that I think are good for patients. Some of the other ones are more for clinicians, but there's definitely some chapters there that are meant for patients. Yeah,
we probably should have mentioned in the beginning that the book is a cardiology textbook. This is not meant for the light reading of a patient with HCM. That's where Dr. Maron's book and my book and his come into play. That's the 150-page version of this in a snapshot. So they complement each other quite nicely. If anybody's looking for the book, we will be working on putting a link up in the next couple of weeks where you can get it directly through the HCMA. So we will be working on that. Sorry, I was a little slow on getting that going, but we will get this up. And if people want it, they will be able to buy it. And they can just come straight here and get it. So is there any other chapter you want to talk about before we let people ask questions? And if you want to ask a question, we can go with general HCM questions. We can't answer your specific needs, your case at this point. But if you have a general question, start typing now. And when I say hit send, you can hit send, and we'll put those questions up on the screen. But Hari, is there anything else that?
Yeah, sure. I was very happy to have a chapter on the right heart and sleep apnea. I think obesity, sleep apnea is a big problem. Hypertrophic cardiomyopathy can certainly trigger atrial fibrillation and more weight. So I was very happy to have that chapter. I think the chapter on hypertension is a big one because as I did the first edition, I realized one of the common problems we have is patients with hypertension and hypertrophic cardiomyopathy. Very hard to treat. First, there's a confounder there in terms of how much of the disease is from the hypertension versus the hypertrophic cardiomyopathy. But once you've made a diagnosis of the hypertrophic cardiomyopathy, certainly the ones with obstruction, these patients are very hard to treat from a hypertension standpoint. I'm not a huge fan of clonidine, so I end up trying to be more aggressive with either their myectomies or whatnot, or the ablations to try to improve their obstruction so that they can get ACE inhibitors and ARBs. I don't know if that's necessarily what's going on all over the world, but I think I've been more and more reluctant to lead patients with very severe hypertension just because they have obstructive physiology. What's been your experience with that, Lisa? I'm sure you have a lot of patients on multiple medications.
We have a lot of patients who have both hypertension, so high blood pressure, and hypertrophic cardiomyopathy. It's really difficult to manage both conditions together because if you're obstructed, like you were saying, the medications actually play against each other.
Right.
So talking in layman's terms to those who are watching on Facebook and soon to be YouTube, when you have hypertension, the drugs that they tend to give you vasodilate you, and they move the blood out of the heart and into the veins, and thereby lowering your blood pressure. But when you're obstructed and you have obstruction and you have hypertension, the medications actually make your obstruction worse in some cases. But sometimes you need to balance the two of them, and these are really tricky things to do.
Mm-hmm.
And one of the reasons why we definitely recommend Center of Excellence Care, because sometimes we can find good balances, but oftentimes it's off to surgery or ablation, get rid of the obstruction, and then we can get down to dealing with the hypertension, and then we can start moving forward.
And sometimes those patients are then the happiest because they're on less medications and their symptoms have improved. But the other thing to mention there is that some of these patients with obstruction from hypertrophic cardiomyopathy and the hypertension, they start getting ACE inhibitors or ARBs, and lo and behold, their hypertension goes away.
Right.
Okay, and that's because in many of those cases, because they've gotten completely obstructed they have a resting obstruction so that their blood pressure just kind of tanks. And their pressure is better, but now they can't breathe. Now they have leaky heart valve, mitral regurgitation, they may have atrial fibrillation that's a higher risk. So it's a false sense of security. And I think ultimately, especially since our patients are oftentimes middle-age, 40s, 50s, 60s, these are not patients that you can keep with hypertension going for 20, 30 years because they're ultimately going to get kidney problems or strokes or atrial fibrillation. And so the field is probably moving towards being more aggressive with these patients to get rid of both the obstruction and the hypertension.
I'm having a hard time remembering this now. Did we talk about anticoagulation at all in the book specifically?
Well, we talk about it in the AFib chapters.
In the AFib chapter.
Yeah.
An often asked question lately is, do I have to go on warfarin, or can I go on one of the newer drugs? And are there any trials in HCM with the newer drugs? And the answer is we're learning from the general AFib community. We don't have specific trials with Eliquis and Xarelto and all those. But what are your thoughts?
Yeah, I mean, my thoughts are that, there's a lot of benefits to the DOACs and the NOACs, as they call them, which are these pills that you can take without monitoring, as opposed to Coumadin. And I think the benefits, obviously, are that Coumadin doesn't work for everybody. It changes based on your diet. And so we don't have head-to-head comparisons in hypertrophic cardiomyopathy, but we do use a lot of these DOACs in patients with hypertrophic cardiomyopathy and AFib. The first thing to tell people is that if you have any AFib, hypertrophic cardiomyopathy is considered a high risk for stroke. And I think last time I looked at the data, it was the third leading cause of death in hypertrophic cardiomyopathy. So strokes from atrial fibrillation are not minor strokes. They tend to be pretty severe strokes. So you don't want that. And I'm talking to Lisa, I know your history as well.
29 years ago yesterday, I had my stroke, but it wasn't due to AFib.
Okay, yes, correct, but yes. So I do believe in it, and I think REP guys use these medications for any patients with any amount of atrial fibrillation. In the non-HCM community, if they have minimal burden of AFib, sometimes we stop them, but in this community, we tend to keep them on pretty much permanently, unless you can really show that you've ablated it and got rid of it. But honestly, my suspicion is that it's very hard to get rid of this if you still have the hypertrophic cardiomyopathy heart. It's likely to come back. We do need data comparing the two, but in the absence of that, I think it's reasonable to use, for compliance reasons and for efficacy reasons, the new medications.
I think that'll come in time. I really do. I think our databases are growing. We have a collaborative community right now. I think these questions will be easily answered soon.
Right.
Those people who are afraid to get off of warfarin and try something else, right. I would have you work with your docs locally, and I think I've seen it done safely in many people. So have the conversation and see if you might be a good candidate. Yeah,
we do it in patients who have a device in place or a loop recorder where you can really be sure that they're not having atrial fibrillation. I think those are relatively safe areas to do it in, but you need vigilance there. Somebody needs to be checking those monitors, checking the pacemakers and defibrillators. The settings have to be appropriate to catch all this, so that you know for sure that they're not having a high risk of AFib and stroke.
So the images in the book came out great. Nice,
yeah, I think one of the things that we did the second edition was to have all the images in-house, have more flow sheets. The chapters were all updated. About 10 new chapters, as you see. I'm at a loss for what the third edition is going to be, but I'm sure there'll be one.
Well, you have a topic here that might have that answer, and that is we're looking at novel approaches to therapy. What's coming next?
Well, there is a chapter there. You got to get in there. There is a chapter. So what's coming next? There's several companies coming out. That's actually the most fascinating part of where we're going as a field right now. There are several new medications, at least two main ones that I can think of that are in the pipeline. That can work in both the obstructive and possibly even the non-obstructive form of hypertrophic cardiomyopathy if we look at endpoints in terms of quality of life and effort tolerance and how far they can walk. And interestingly, some of them look to be, at least in terms of a symptomatic relief standpoint, as good as surgery and alcohol ablation, or at least close to it. I think that would be really great if we have therapies that we can try on patients and make sure they don't have complications from it, but they have the same effects as a open heart surgery or an alcohol ablation, then these patients can avoid those for some time. I mean, right now, the closest we have is the beta blockers, the calcium blockers, and then Norpace. And Norpace does work, and I think in probably the majority of patients to a certain extent. And these medications may mimic that and do a better job without some of the nuisance side effects of the Norpace. Now, they have their own potential risks, but so far in the trials, they seem to be well tolerated in the doses that they've selected.
The devil's always in the details, so we wait cautiously optimistic for positive results, but we never know until it's
done. And we'll have to learn about them, right? So even when they come out, we'll have to see in a larger population, are the side effects going to be worse, the same, or better? And we'll start fine-tuning which subgroups really work and which ones have a less efficacy. And then there'll still be a role for surgery and ablation in patients who maybe want to avoid medications for the rest of their life. And I think that's a work in progress. Obviously, it's better to do something non-invasive or minimally invasive or non-invasive if you can get away with it first. But we'll have to see. That's going to be where we go.
I'm very, very concerned about some of the cost issues that are related to HCM care. We know that myectomies are expensive. Devices are expensive. Alcohol ablation is not cheap, but much more affordable. Mm-hmm. But where will these drugs come in price-wise?
Yeah, actually, that's a good question. And having been on advisory boards before, they sometimes talk about these things. Where should the price be for the proper amount of uptick in the community? And you're right. And when a new medication comes out, oftentimes it has to be approved by insurance companies, and the cost can be prohibitive to some patients. We'll have to work on that, and that's where you and I come in, and the other physicians to try to lobby the companies and the insurance companies to first take it up, and even to lobby the companies to make the drug affordable. And then we'll say, well, we're going to try to get it out there for you. We'll help you with getting patients on these medications, but we want to make sure that they're available to everybody. And that goes even beyond other countries, but certainly in the United States here. Yeah. That's going to be the first hurdle. We have that in interventional cardiology, where sometimes it's prohibitive. It's pretty expensive over the first few months.
Hopefully we'll work on that one. We do have some questions from our viewers here, so I'm going to pop them up here. First, Tracy had a question that actually is the opposite of what we were talking about earlier. She gets hypotensive. Her blood pressure drops on medication. So how do we manage hypotensive HCM patients?
Yeah, that's interesting. So there are some patients with hypertrophic cardiomyopathy whose pressure is low. First thing you want to make sure is it's not low because they're constantly obstructed. If they're constantly obstructed, I think this is a patient population that we're going to show, just like in the pediatric population, that they do worse. They get more and more obstruction, more and more hypertrophy, and more heart failure at a higher frequency, and they tend to develop symptoms much quicker. So those patients, the treatment, if they're truly hypotensive and dizzy from that, is to relieve the obstruction and you choose the therapy based on their anatomy, their age, and we can get into that at a certain point. But if you have other patients, there are definitely other patients with hypertrophic cardiomyopathy whose blood pressure stays low, and it's partly because they have some component of what's called autonomic dysfunction or autonomic insufficiency, where they're not able to regulate their blood pressure properly in response to the hypertrophic cardiomyopathy. And these patients, sometimes, obviously, you start with hydration, but if they can do it, if they're not otherwise congested. And then there are medications like midodrine that we've used in these patients as well. And that seems to work actually pretty well for the autonomic insufficiency or the inability to control your blood pressure problem in this disease. So midodrine is a medication that's taken 3 times a day. So it's a little tough to take for some people. It comes in a couple doses, but does tend to work in the patients. I think there's a very small subset of patients that have that problem, but it does work in that situation.
Do you use Florinef at all anymore?
I haven't used Florinef as much. But it can be used to raise the salt. I mean, this is the one population where you do advise them to eat salt. I mean, in other patients with heart disease or congestion, they shouldn't have salt because it tends to make them more congested, more shorter breath, more fluid in the lungs. But patients like this, you do not want to restrict their salt. It's okay to be eating salt in those patients because they typically need the salt to raise their blood pressure. But I have not had much experience with Florinef. Maybe perhaps you have from.
It's rare. I was actually on it 25 years ago because my blood pressure would drop out for no reason, and I would have a little salt. I'd take my Florinef and it pop back up. So, the rule book is multifactorial, and the rule book changes with the patient. We do have another question that is, should you remain stable with HCM, or does it always progress? Or is this a case-by-case as general rules?
That's a great question because we have to think about progression in two ways. So the first question is, does the heart thicken? So I think the general rule is that most of the thickening of the heart muscle probably happens in your teens, 20s, and 30s, and then tends to trail off. However, some patients continue to progress, and they may continue to progress in terms of thickness for two reasons. One is they may have superimposed high blood pressure, which is a trigger for thickening more. And second, patients who are obstructive, either having an obstruction to outflow tract, obstruction all the time, or are provoked, that is also a trigger for more hypertrophy. And we know that because if you relieve the obstruction, many of these patients have a regression, or what's called a more thinning of the heart muscle after that relief. So to answer your question, there is progression up to a certain age, and then it might progress more if they get obstructive or get hypertension on top of that. And so those are the things I look for in a patient. If they're not hypertensive, if they develop obstruction, I'm worried that they're going to have more and more symptoms and progress. So the progression in terms of anatomy is different from the progression in terms of, are they going to get worse? Are they going to feel worse? Right. And so I think that many of the patients do feel worse as they get older. And that's a combination of the heart getting worse, the heart maybe getting obstructive, but also in many cases, as we talked about, the body getting worse, getting more obese, getting older, not being able to accommodate any dysfunction like you did. And so it's the combination of how the heart is doing and how fit your body is that decides at some point you have symptoms. And those symptoms then need to be addressed by the medications and the other therapies. But the development of symptoms is a combination of how your body is doing in response to the hypertrophic cardiomyopathy and how the hypertrophic cardiomyopathy is progressing.
Bill has a question. How can you distinguish fatigue caused by HCM versus the side effects of medication?
How do you distinguish which one?
How do you distinguish
fatigue.
Whether you're tired, you've got fatigue because of meds, or because of HCM, or maybe there's another factor?
This is a common question. So the one challenge is that fatigue is very hard to figure out why people are tired, but there's no question you can be tired from hypertrophic cardiomyopathy. So you can be tired from the medications as you go up on the beta blockers. You can be tired because you're depressed about this disease. You can be tired because you have poor sleep from sleep apnea from this disease. And you can be tired not only because of medications, because hypertrophic cardiomyopathy also doesn't circulate as much blood. And so your legs get tired, you get tired. And so it is very hard. The honest answer is it's very hard. So we assess if they're depressed. We assess if they're sleeping properly. We assess what their diet is. Lots of carbs will make you tired as well. So we try to look at all those things. Now, we generally know if you're on 25 milligrams of toprol, it's probably not causing you fatigue. But if you're on 200 or 150 in a small person, maybe it is. And this.
What about verapamil? What about a calcium channel blocker?
Yeah, verapamil can do it, but not as much as the beta blockers, in my opinion. I think the beta blockers tend to do more. They probably cross into the brain a little more and make people more fatigued. And they tend to hold back the heart rate a lot more in those patients than the calcium blockers. So my experience has been the beta blockers do more in terms of fatigue than the calcium blockers, but they both can. So this is also why, some people will keep on going up and up on the medications, but we have to individualize when at a certain point, A, they're not working, and B, they're causing more problem. And that's an individualized basis. We talk to the patient and say, well, these are our options. We can go up on the medication, we can come down the medications, or we can try invasive therapy and see where you're at. And sometimes by doing that, you're able to minimize the medication. So I'm not trying to advocate that everybody should get invasive treatments for their disease, but there are patients who at some point, that's the best way to minimize the medications and improve their overall symptoms.
It's a complicated path, though. You tell somebody, take the medication, you're going to feel better. Now, my experience has been the first 3 to 4 weeks on a beta blocker, there's a lot more fatigue because your body's getting adjusted.
Absolutely.
So I try to tell everybody, hold it for 6 weeks. Yeah, you're going to probably be tired.
Right.
But after that, your body tends to acclimate to it, and the
Yes.
fatigue is not as much.
I absolutely tell them that. Now you're not surprised that many patients will quit the medication in the first couple of weeks. They take it, and all of a sudden they feel tired. And I tell them 2 things. One is that your pulse will be a little lower. Okay. You may feel more skipped beats, honestly, paradoxically, because if your heart rate's slower, every single extra beat is more palpable, for lack of a better word.
Mm-hmm.
And then it does take about 2 weeks for your body to get used to the fact that your heart rate's less, and so your heart actually has to squeeze more at that point.
Right.
So I tell people to take it every day, as we're describing, usually twice a day, sometimes once a day, but don't judge it until I see you next time. Just have to trust me. Take it for the whole month, and then at that point, we'll look at it. And as you know, some people have a very dramatic response to beta blockers. They're clearly very symptomatic. They start the beta blockers, they up-titrate after a couple of weeks, and they feel 100% better. And those are probably the patients who have what's called latent obstruction. Those are the patients who have no resting. They don't have obstruction all the time, but they have obstruction when their adrenaline is up. And that's what the beta blockers help preventing. And those patients get no lightheadedness, and all of a sudden the symptoms go away. Whether that lasts forever, we don't know. So those patients, we watch them over time, and the ones who do well, and the ones who continue to progress, as we discussed, may need more medications or additional medications or go on to invasive therapies.
So we have a hello here from Esther, and she's just chiming in to say thanks and let everybody know she's doing great. So backstory on Esther real quick. We've talked about this before, so I'm not disclosing anything. She's up here. I first met Esther when she was 8 or 9, obviously through her parents. She went away and became an adult and a parent herself, and the next thing I know, she's showing back up needing a transplant. And she went up to Westchester where she was evaluated, and she's doing great today. Okay, so who else do we have here? Victoria. Does this belief still hold that younger onset of symptomatic diagnosis more likely will become more progressive, or has that changed over time?
So, and you can chime in on this as well, Lisa. Obviously, you have thousands of patients you've seen, but my suspicion is that the younger you are, you're likely to have the genetic mutations, first of all, that typically relay more massive hypertrophy. By massive would mean 2.5, 3, or more than 3 centimeters. So the younger you develop it, the more likely you are to have the types that tend to have what's called diastolic dysfunction, so much thickening and so much of encroachment into the cavity of the LV that the heart actually is larger in thickness, but it's actually smaller in terms of what it can accommodate. There's less blood can get in. So this is also the reason why a lot of times the younger patients need open heart surgery, because there's just a lot of muscle that needs to be excavated to improve the size of the heart. So yes, if you're 25, 30, you have a more severe form in terms of the hypertrophy typically. The older patients who develop it in their 40s, 50s, 60s tend to have a smaller amount of muscle right at the outflow tract. And, we're getting into the details here, but that's also why these patients do really well with alcohol ablation. So this old debate about alcohol ablation versus surgery, it really depends on the anatomy. And we have a program here where we have a heart team, and Lisa knows our surgeons. We've been doing quite a few now, probably about 30 surgeries a year now. We're on clip for this year, and we do probably 30 to 40 alcohol ablations a year. But there's no competition. We know which patients. It's very obvious when you look at the anatomy which patients are going to do just well with ablation and which patients are going to do or really need the surgery. And my surgeons were always not complaining, but to say, how come we're always getting these massive hypertrophies and younger people who also tend to be more overweight? And that's the nature of the disease, I think. These younger patients with thicker hearts, they tend to get more obese because they can't exercise, and then they need more invasive therapies. Yes.
So we go back to what we started talking about earlier, and that is this paradox of I can't exercise because I don't feel well. I gain weight. I feel worse. I don't exercise. I gain weight. I don't feel well. And it's this cascade. I would really love to see us put together a clinical trial on the use of cardiac rehab for all HCM patients to teach them how to exercise comfortably, safely with their body. And insurance companies are going to give the pushback that they only give cardiac rehab to people after a cardiac event.
Right.
I think if we teach our people how to exercise safely, before things start to fall apart will probably save a lot of money in healthcare.
Well, I think you're right. I think, well, there's a few things. One is that, as I mentioned, if you take somebody with this disease and you keep them fit, they may be able to completely avoid some of these invasive therapies, which ultimately the insurance companies, would be happy not to pay for if they needed it. The other thing, honestly, I'm thinking about it, as you mentioned, is that if you do proper cardiac rehab and you teach people how to exercise healthy, you probably make them less anxious and less stressed about the risk of sudden cardiac arrest and less mental illness.
Which brings up the next question here, which I was kind of hoping you might mention. So Kitty, who asked a question earlier, said she's mild, no obstruction, but she has severe anxiety. Now, we know that a lot of patients with HCM, first off, are diagnosed as just being anxious before they're ever told they have HCM. Because they just feel something abnormal in the chest. And you can't relate, but I can. I had an abnormal heart since I was 12. And sometimes it does funky things and you go, uh-oh, and you get anxious. And if you have a propensity towards anxiety anyway, they start to fight against each other. And it is a vicious cycle.
Right.
So exercise is great for combating anxiety, as you just said.
Absolutely.
But should patients with HCM who also have anxiety be treated for that anxiety more holistically? Or should we
I think so. So, I think that people are anxious with HCM because of the risk of sudden cardiac arrest. Even though the risk is relatively low, it's a lifelong risk. The second thing is that you're absolutely right. These thicker hearts, one little extra beat, they feel it. They feel a strong palpitation, much stronger than I would feel without hypertrophic cardiomyopathy. So if you live your whole life, every time you have coffee or you have something else, your heart starts skipping and and it feels like it's pumping out of your chest. You're going to be anxious about that. And then on top of that, if you start getting some arrhythmias, even if they're minor, non-life-threatening arrhythmias, the heart's not going to feel well with that. And you're going to get more and more anxious about, is there something wrong with my heart? You're feeling it all the time. And then that begets more feeling it all the time. So I think the depression and anxiety is not well treated in this disease. Right. I absolutely think I'm a big proponent for therapy and seeing people to help with anxiety because it's a lifelong disease. And people have to learn how to live with it and how to minimize those symptoms and I think exercise is a big way because exercise has lots of benefits in terms of making people feel capable and body image issues and also just what they're able to do safely.
I'm going to ask you a weird question that doesn't have a clinical answer yet. Do you think it is possible for patients with HCM to not process adrenaline properly?
I suppose it's possible. We'd have to map out that mechanism, but we know that the adrenaline can cause lots of things in the body. People can have heart attacks from adrenaline. People can have arrhythmias from adrenaline. Adrenaline is basically the catecholamines or the amphetamines of your body. So your question really is are they also more sensitive to it somehow? And I don't know. I'm not sure it's been mapped out yet, but I wouldn't be surprised if this muscle is not only abnormal in terms of how thick it is, but maybe it may be more prone to those things.
I think if we just give it a little bit of adrenaline and we say, okay, we need, it's the fight or flight response. We need to run away from the tigers now. So we get that little burst of energy and our heart kicks up.
Right.
We feel it more than other people would probably feel it, is my thought.
I think you do. And I think that might be some of the benefits of beta blockers too. They block some of that so people feel better. People definitely say that they feel a lot less anxious with the beta blockers. I think one of the comments mentioned that as well. They definitely do. And beta blockers are also used for stage fright. So it definitely helps with anxiety and palpitations and calming things down. And even though we don't have the data that beta blockers prevent sudden cardiac arrest, my own thought is it probably doesn't hurt. And to show that it benefits them would take thousands of patients, and that might be why we haven't seen that.
So I'm going to address Dolores' question here with a non-answer answer. I've been on bisoprolol, I guess you're saying, for 15 years at 7.5 milligrams, and the doctor's taken me off because my heart has gotten lazy. I'm nervous as I'm on them too long. Should I be nervous?
Well, I don't know what lazy means. I think I would first ask, I'm hoping this person is being seen by a hypertrophic specialist, because the first thing is that sometimes the heart goes from being too strong not being lazy, I'm not sure that's the right word, but to being somewhat weaker. And that's what we call burnt out, HCM. And I don't even like that term because in many of these cases, it doesn't burn out completely. It kind of waxes and wanes and may actually get better again. And so I think the first question is, what exactly are we talking about in your heart? Is your heart getting weaker? Are you having more heart failure, more symptoms? And if that's happening, I don't think I would blame the beta blocker. Beta blockers don't do that per se. I think we would blame the disease progression. And then many times you have to be changed in terms of your medications and may need other things. Sometimes you need defibrillators in that setting, and sometimes you need to be worked up for more what we call advanced therapies. But to be honest with you, I tend not to jump the gun on that. I tend to back off on the beta blockers there and watch over time, switch to what's called ACE inhibitors, which are different types of blood pressure medications. And I'd say half the time it gets better, and it may get better for a significant amount of time. Now we also have MRI. MRI is helpful to see what's actually going on in your quote unquote lazy muscle, and we can see if it's a real problem or not.
We're going to be talking a bit more about that in the next session we do, or an upcoming session. I'm going to have Marty Marin on here discussing his new paper on sudden cardiac arrest risk assessment and new lessons learned, and that information will be in the next guidelines. But the paper was just issued a couple weeks ago. We put it up on our page. It's really interesting to see how much MRI has helped us identify those high-risk patients. Yeah. So we've really struck a chord here with a lot of these comments. A lot of people are resonating with the anxiety issues, that they feel them as well. A lot of people would love to go to cardiac rehab, but Phil's asking an interesting question, which is a tricky one again. How would a heart react to epinephrine? I use an EpiPen because I have allergic reactions. And we were just talking about that before we went live, about allergic reactions. So if you got to use an EpiPen, right, you got to use an EpiPen.
I think it's a matter of risks. I mean, I wouldn't go around stabbing yourself with EpiPens all the time for no reason, because obviously with every adrenaline rush, and an EpiPen is an adrenaline rush, it's meant to be a certain amount. So it's not meant to be so much that your heart's racing out of your chest all the time. But you have to think about it. What you're using the EpiPen for is if you're having a severe allergic reaction, it's going to save your life. And I always tell people one of the things that, and my son has a peanut allergy, so I'm very sensitive to this. It's one of the few things, anaphylaxis or a severe reaction, that you really need EpiPen. There's no other substitute for that. Does that mean that you might have a small risk of arrhythmia from the heart? Yes, but that risk is much less than the risk of you having a serious problem by not using the EpiPen. So use the EpiPen and go right to the hospital, as they instruct you to do. But you need to know about that you have two conditions and they work off of each other. Obviously, the best way is to avoid ever needing to use the EpiPen, and I wouldn't use it for mild reactions where you might want to use Benadryl, and I'm not your doctor, so I'm not going to tell you to do that right now, but certainly you should ask your doctor what's a mild reaction for which you can use Benadryl, as opposed to going right to the EpiPen for everything.
Yeah, I have, and this is something most people don't know, and I don't even think you know, I have idiopathic anaphylaxis. They can't figure out what I'm allergic to, so I carry an EpiPen at all times. And I think I'm going to be more likely to use that EpiPen on somebody else than ever using it on myself. Yeah. But back when I had my old heart, they gave me an EpiPen Junior, so it would be a lower dose because they were a little nervous about that. So that's something you can talk to your doc about as well. Yeah. But then a new doctor said that they wouldn't give me a Junior because my body mass wouldn't match it. And
they wouldn't do it. Yeah, it may not. So that's, we don't have a lot of evidence here. I mean, my own preference would be to give the full EpiPen because I think I'd rather treat the anaphylaxis if it's real properly, and then get you to a hospital where we can address the rest of it if needed.
So somebody just asked, and we're going to do like 3 or 4 more questions, then we do have to wrap up because there's a doctor there who has patients he has to get to, but we've got him for a little while. So somebody asked about cortisone shots in the shoulder. They're fine. You get that little that rush. And you don't sleep for a couple days in most cases, but I don't see there's any kind of.
Yeah, I don't think it'll affect the heart. That's fine.
Anywhere. And Scott, let's see what your question is. I'm doing this without glasses too, so that's why I do this over here. Without beta blocker, Z beta, and doing cardio, heart rate goes up fast. Now on beta blocker working out, it doesn't. Is that a good thing, or am I only masking my heart rate? And that's kind of what we want it to do.
Yeah, I think it's a good thing. It's not masking your heart rate. That's your real heart rate. And actually, by doing that, your heart and body have to become more efficient because it has to pump better and your body has to extract oxygen better. So I think it's kind of a win-win for hypertrophic cardiomyopathy patients. Obviously, other patients who don't have hypertrophic cardiomyopathy, they shouldn't be on beta blockers because it may minimize the amount you can exercise. But for hypertrophic cardiomyopathy, it's exactly what we want to do.
So, Kitty, I'm reading all your messages here, and what I'm going to ask you to do, dear, is contact the office. Let's set up a time to talk, and let's go over all of this. If anxiety has been ruling your life that much, and HCM is causing you anxiety, let's make sure your HCM care is on the right plan. We'll work with you to set up a plan, make sure you're with the right docs, and that you have access to these resources, and that you don't have to worry so much about your HCM. I can't take away the other anxiety that might be in your life, but we can try to help you through your HCM anxiety. So thank you to everybody who has participated in this Q&A session. I want to wrap up by bringing the book up once more time. And this is, look, Srihari Naidu. Confuse everybody with that first name thing, right? Yeah. This is the second edition of this book. It is a textbook for professionals mostly, but there are some things in here that patients might find helpful. And if you're, a big data geek like me and you want to know all the details, you can go ahead and get the book yourself. We will put it up on the HCMA website ASAP. We're going to get that all set up in the next couple of days for you. And I really appreciate y'all being here with us today. I appreciate Dr. Naidu's time today. And we look forward to having more of these conversations in the coming weeks and months, and God only knows how long. And I'd be curious about your thoughts about HCMA as a podcast. Would you be interested? Would you not? I think we're going to start one. And it's
I think it looks like there's a lot of interest in these kinds of discussions. So
there are, and I've already named it. I haven't set it up yet, but it's going to be Tales from the Heart. Mm-hmm. And it's going to be all different things related to HCM, from the clinical side to the patient side to the weird stories that we encounter. And yes, there's actually HCM humor involved here too, because there's some really strange things that happen. And there's really sad things that happen. It's all things HCM. So be curious about, your input about topics for podcasting, style of podcast, and length of podcast. I'm trying to organize those things before we launch. So if you have any comments on it, send them on over to us either through Facebook or you can email the office. Dr. Naidu, thank you for your time today.
My pleasure. I enjoyed it. Thank you for having me.
You're very welcome. Thanks, guys, for watching. Stay well.